according to the standard of care, there's probably 5 things we can do to help you. 1 is I can send you to a qualified rehab professional. 2 is I can give you a brace. 3 is I can give you some medicine. 4 is I can give you a shot. And 5, we can operate on you.
Okay.
And a lot of the people I see are here because they're like, I don't want surgery, or someone told me I needed it. Do I really need it? Or I'll do anything to not have surgery, or it just depends, right?
Yeah.
But we see a lot of people who don't want to have the rehab time.
Welcome back to part 2 here at Beyond the Pump, where we are spending some time with Dr. Trevor Turner. Again, physical medicine and rehabilitation physician, world-renowned expert in a lot of things. And he's going to be talking us through some of the top interventions that PM1R physicians, or realistically coaches, should be aware of that may not be commonplace, that can really help get some of those clients that might be stuck with some clinical issues, maybe certain things, and just giving you some background and information on what exactly to ask, what to look for, and how some of these things even work, just to get you exposed to that world. So, Dr. Trevor Turner, thanks so much for being here. What do we got on the docket for top interventions?
Yeah, thanks for having me. So let's say somebody comes into the clinic and their knee hurts, and we're diagnosing them. Usually we say, okay, according to the standard of care, there's probably 5 things we can do to help you, right? Yeah. 1 is I can send you to a qualified rehab professional of some kind. 2 is I can give you a brace. 3 is I can give you some medicine. 4 is I can give you a shot. And 5, we can operate on you.
Okay.
And a lot of the people I see are here because they're like, I don't want surgery, or someone told me I needed it. Do I really need it? Or, I'll do anything to not have surgery, or it just depends, right?
Yeah.
But we see a lot of people who don't want to have the rehab time. I would say in the last 5-10 years, there's been a much bigger push towards, okay, well, anti-inflammatories don't really help me very much. Is there another kind of medicine I can take? You can edit that part out, right?
Yeah.
Certainly and some people are using peptides now, which are technically, classes of medication, some of which are FDA approved, some of which are not.
Interesting.
And a lot of people are using that for soft tissue recovery. And of course, there's a lot of regulatory complexity around that. Then as far as procedures go, I do procedures typically through a needle, occasionally with a micro drill, but usually for those, obviously, we would give somebody sedation. So there's a lot of patients who are like, I don't want any kind of anesthesia. So what can you do that doesn't require sedation? Or they'll say, I don't want to feel a thing or be awake. I want to be sedated for everything, and it's like, okay. And there's a balancing act, I think, there. But most of the time, if we're doing a procedure that is not a steroid injection, which I hate and almost never do anymore, because they don't help people for the long run, typically we're having discussions about, should we take something from you and give it back to you? And usually those things are either coming from your blood, and usually if that's the case, they're platelets, and that creates something called PRP, which is pretty, I think, well known in the sports and athletic community now. And we've been doing PRP in the United States really since the 90s, but probably got big in the early 2000s. Then when people start looking at adult forms of stem cells, which we call MSCs, or mesenchymal stem cells, those are usually harvested from one of 2 places, either bone marrow, and there's a lot of very good data for bone marrow, although a lot of times if you're sitting in a room with a patient and you say, hey, I'm going to aspirate bone marrow, that's what they do, and then they say, I'm terrified of that, I don't want that. Or use a harvest that comes from adipose or fat. And we call that MFAT when we do it for microfragmented adipose tissue. A lot more data in the last 5 years in particular for the use of adipose-derived stem cells than there were in orthopedics before that. So we're seeing a much higher utilization of it. And frankly, most people, if I say, hey, I'm going to take some of your fat, they're like, well, take some extra while you're at it.
It's like liposuction.
Exactly. So it is technically a miniature liposuction procedure. But anyway, so all of those things meet the FDA's criteria, which basically is that, you can take those cells from the same person or a first-degree relative. You can do it within a 24-hour period. You have to use what's called homologous use, which is probably the most complicated part of the guideline, which kind of means like whatever cell you're taking has to perform the same sort of biological function in the place that you put it. Very easy argument to make with PRP because you have blood
Yeah.
basically everywhere. Bone marrow forms a lot of the support cells and cartilage and extracellular matrix everywhere. Fat is in a lot of places, but maybe not everywhere. So depending on the physician and their comfort level. And then the fourth or the last criteria is called minimal manipulation, right? So that means whatever we harvest, we can put it in a laboratory setting in a centrifuge that spins really fast, that use gravity to separate things. We can throw away the things that we don't want. We can concentrate the things that we do want, but we can't like add things to it and chemically modify it and put other things in it because then it becomes an unlicensed drug, right? So everybody wants to be regulated like a physician in the practice of medicine and not like an unlicensed drug, right? So anyway, so those are kind of under the regenerative umbrella, really the things that in the United States meet, quote, compliance. There are people obviously out there using what are called allografts, which means they're getting something sent to the clinic from somebody. It's not from you. And that's different from an autograft, which is really what we do, where we can be very confident about the safety if we take something from you and give it back to you, right?
Yeah.
So, and then we've got, clinical trials and other things going on where people are doing, stem cell expansion where they grow it on a plate and then they give it back to somebody. That's not something we can do in the U.S. outside of a clinical trial, but there are people obviously doing it and studying it, and there's good reasons for and against that. But and then another thing that we've really looked at is like synergistic effect. Okay. So a lot of people have said, okay, well, like I've done thousands of cases now with PRP. I'm really good at understanding who should get it, who should not get it, if they get it, how concentrated should it be, should it have white cells in it, should it not, should it be activated, should it be inactivated, blah, blah, blah. There's all these modifying factors, right? And then people said, well, what if I give somebody hyperbaric oxygen? Or what if I give somebody shockwave? Or what if I give them laser? Or should we do both? Or how often should we do it? Should we do it before we do PRP or after or whatever? So there's all these extensions where people are trying to iterate and say, well, how can I be 5% better, 10% better than I was last year, right? And people have tried to talk about this field of energy medicine, which to me it's kind of a difficult word to use because you're like, what does that even mean? But I think people are using it to broadly encompass things like shockwave and laser, which we call formally photobiomodulation, to be able to see if they can synergistically enhance people's soft tissue recovery and therefore long-term outcomes as well.
Interesting.
And so we've, have started doing that here. Sometimes we can use orthopedic laser, which is a class 4A medical device. So it's a high power device. Because it penetrates deep tissue and it keeps people from needing a procedure with us. So if you're an in-season athlete, man, that is like gold, right? Because you can't really take time off to recover. A lot of the regenerative medicine procedures we do are, quote, off-season procedures because you've got a 6-ish week to 12-week timeline for full effect to occur, which obviously is not an option if you're running the New York Marathon in 3 weeks. So it's up to us to help make responsible decisions that way. And then there's people who are saying, okay, well, I'm coming in for a procedure like this. How can I minimize my pain and enhance my recovery, right? And one of the things, anecdotally, we've noticed that we've not published this data, but the people who let's say for knee arthritis, come in and get like a regenerative treatment with PRP done, if we use laser post-PRP at that same appointment, so we finish doing the procedure and then we use it immediately after, their pain and inflammation post-procedure is significantly lower, right? Which is great because I'm in the business of not trying to give people pills for everything. So if I can reduce your need to take pharmaceuticals, most people or most patients I see consider that a win.
So with that in mind, because obviously that's a pretty broad picture of a lot of different things here. First follow-up question I have before we get into like some of the mechanistic items, helping coaches understand how the PRP stuff works, how the laser stuff works. You mentioned the FDA criteria. Now, looking at that, understanding just very briefly like the legislation and stuff around that, does FDA criteria mean safe? Does it mean effective? Does it mean as on-label use, like what exactly does that promise the consumer if they're looking for that? Because you obviously mentioned the off-label uses of like peptides and compounding pharmacies and so on and so forth. So is that something that should be a large consideration for consumer?
I think most consumers don't know about it, to be honest. I think most of them are like, I talked to my friend and they had a good experience here, so I'm going to go there. Because most of them are not reading peer-reviewed, validated research. Although I would say now with the advent of artificial intelligence, I have a lot of people using artificial intelligence tools that will come in and ask me very sophisticated questions to the point of like, what anesthetic are you going to use for my local anesthesia? Because I don't want it to compromise my PRP. And I was like, that's a great question. Like we always prefer to use ropivacaine, blah, 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 blah. So, I do think there is on average, a smarter and more sophisticated patient now than there was even 15 years ago when I guess I started started residency, 15 years ago. Which is really cool because I think when people know more, they're more bought into their outcomes, right? I think one of the things that, has been a little frustrating for the group of regenerative medicine practitioners that are trying to kind of lead the field is you do have some people who are just either don't know the guidelines or they're blatantly disregarding them. And there's been some very high profile cases where people got really, really hurt. And in that case, the FTC and the FDA step in and then it becomes a big legal thing and whatever. But there are small people out there that are not on the radar of the FTC and they're doing stuff that's probably not that safe and they're not very good at it, right? And I don't have a problem with people doing quality research. Like we should be asking questions and doing that research for sure. But it's expensive and it's hard to do that, right? And sometimes practically it's hard to randomize it. But so we, like early on in my career, when people would approach us about using an allograft, which is very common in the world of like wound healing, right? So somebody has a chronic non-healing wound, they need something to lay down on top to give them better tissue. They would get a product mailed. We use stuff like that in the burn ICU when we were treating burn victims, et cetera. So that's not weird, right? But the weirdness becomes is when you say, this is a stem cell product, and then there's no living stem cells in it because it's been irradiated at the point of care, which is good. That radiation keeps you from getting a bloodborne pathogen, right? That's passed on with the tissue. But then if we say, can you send us a sample that we can send to an independent laboratory to see if any tissue grows out? And then if 0 stem cells grow out, you're like, hey, right? The other hard part about that is the thaw process sometimes. So you can take an allograft that has quantified cells in it that's frozen. You can rewarm it, basically, which you have to do before you would give it to a patient. And we're not doing this, but you lose vitality really, really quickly through that process, right? So then one of the things we try to quantify is not just the number of cells, which is part of it, but then how many of those cells are viable, right? And so both of those concepts are really important. Now, is the average person who hurts going to ask those questions when they go to the doctor? Probably not, but could they or should they? I would love that, right? But it, it's expensive to measure and quantify everything. But to me, if we're going to take care of patients, we owe that to them, to make sure that you can be confident and that you're safe.
Yeah. So it sounds like, and guys, if you're wondering, we'll put an AI, a ChatGPT prompt that you can use to start understanding some of this stuff and what questions to ask your provider. Great call out on that one. Definitely ramps a lot of that understanding process up. So then to kind of close the loop on this question, FDA criteria, essential, not essential?
Well, essential if you want to be a physician that doesn't get your practice shut down.
That's fair.
But yeah, I mean, I think I'll give you an example. Most of the time, if there are procedures where we pull more than one graft, right? So maybe we're combining PRP with MFAT or with bone marrow for something, or maybe you come in and you've got less severe pathology in one place and you've got more severe disease in the other. And so we say, hey, you get a lot of bang for your buck with something milder at this site and something, stronger or more robust at the other, right? So we'll do procedures like that. But let's say I see, a person who is super sick or super old, or maybe they, have some kind of autoimmune disease where we know their outcomes are not going to be very good. And maybe they've got, 6 different things that need to be treated, or 7, or multiple layers of their spine. And then usually I'll say, listen, like if we help you, it's going to be come back every 90 days for, 3 very sophisticated procedures, blah, blah, blah. And some people may be like, you know what, like not really here for that. Right. And that's okay. I mean, I think that's fair. And so if patients then start looking and they say, okay, well, I can go to Panama or I can go to wherever, where should I go in the event that I want to get, culture expanded cells, right?
Sure.
Which probably does make a difference for the ultra sick, numerous site person that is not going to have a good quality graft anyways.
Yeah.
Most of the people that walk in our clinic are not like that, right?
Yeah.
And it's not because they don't hurt or they don't have severe disease. It's just that usually between 2 or 3 grafts, even with a multi-site procedure,
Sure.
we can usually take care of them and do very effective work without going to extremes, I would say.
Got it. So it sounds like it's just more clinician dependent. Obviously, there are like legal protections that the U.S., whether they're politically motivated or not, obviously there's some of that goes in the background. But basically, the takeaway for coaches is you need to do your homework on, again, exactly what we mentioned in the end of the last episode, how to find a good provider. I think we said experience, education, collecting the outcomes. So if you haven't checked that episode out, make sure you go revisit that. Or can they email you if they have some questions?
Definitely would love that. I'm at tturner@pravita.com and have a great staff here too. So we love being collaborative with other experts in the space, and that's how our patients get better. So
there we go. So if you don't know where to go, this is a great nexus for you to maybe start some of that exploration. But I will say that if you have the opportunity to go and use that ChatGPT prompt just to generate some good, meaningful questions that will help you understand what to ask, that's definitely going to be your first step in going and doing your own independent research. So you've mentioned now here, Dr. Turner, like the PRP, the MFAT, you've mentioned a couple of these different things. Which one of those is probably the most prevalent, and how does it generally work from someone that maybe hasn't taken an anatomy and physiology class?
How does PRP and MFAT work, was your question?
Yeah. Well, which of all the things that you've listed in the prior, which ones would you say are most prevalent? I would assume it's PRP.
Definitely PRP.
Okay.
Yeah. And, the question is like, PRP is a growth factor procedure. It's not a stem cell procedure.
Okay.
Right.
So what does that mean for like people that may not have, when people think stem cells, they're probably thinking like Christopher Reeves, like baby, kind of embryo, fetus kind of situation.
Yeah. So let's say you fall and get hurt. And if you have an acute injury, your body sends a bunch of platelets to that site to form a plug. Okay. And that plug at that site then releases a milieu of growth factors. Okay. And we know a lot about 7 of them, let's say. And there's about 400 different proteins that exist in PRP. So in some sense, we're still kind of scratching the surface from a cell biology standpoint.
Oh, wow.
However, if you think about the fact that your immune system is sort of already doing this when you have an acute injury, we are more or less duplicating that, maybe with the only difference being that as we super concentrate those number of platelets down, depending on how sick you are, how old you are, what degree of injury you have, et cetera, we're kind of trying to supercharge that immune response, right?
I see.
And so I do think there's been a lot of debate like about how stem cells actually work. And I think in the beginning, the thought was differentiation, right? Which is this idea that, we put a stem cell in a place, let's say it's a place where you don't, you have a cartilage injury or you have arthritis, and the stem cell like turns into new cartilage. Well, turns out a lot of the time, if not most of the time, that's not what happens, right? And the reason I would say it's not what happens is because we do have some patients who would, let's say they'd get an MRI, and we do a procedure for them, and they would do great. Like their clinical outcome would be very, very good. They'd be very happy with their results. Now, if that's the case, their insurance usually doesn't cover the next MRI because they're like, well, you're not hurting. Why would we pay for it? Yeah. But some patients don't care, right? And they just want to see it, and they want to know to what degree we can see stuff with ultrasound. I love doing follow-up ultrasound, right? Because then we get data in the office, and we don't run into that problem. Yeah. But you will see people where not all of their pictures really look that much better, but yet they've improved dramatically, right? So there obviously is differences between structural disease, right? So obviously if you rip your ACL in half, structural problem, right? And then chemical or biochemical disease, right? So we know if you tear your ACL, a biochemical process starts in your knee and you accelerate the formation of osteoarthritis much, much more quickly, right? So in that person, maybe I don't need to try and put PRP in their ACL, even though we do that for partial tears, but not for full tears. But if we treat that person after surgery when they get their graft placed, we can significantly reduce or at least delay the amount of time to which osteoarthritis would begin in that same joint, right? So that's a sense where I'm like, okay, well, I'm helping you with the biochemical problem. Maybe I'm not helping you with the structural problem, right? So changing biology, I think, is a big part of it. Interactions with the immune system and immune response and signaling of the other cells that are sitting sort of quietly in the neighborhood that are just asleep, you know, and turning them on and waking them up to do more structural, you know, start doing structural repair really helps, right?
Yeah.
And so that would be, I would say, if somebody asks, like, how does it work? I mean, in some sense, in the first 2 days, it is, quote, inflammatory, which is why we tell people not to take anti-inflammatories after a procedure like that. But, you know, there's a big difference between the soup that we see with acute inflammation versus chronic inflammation, right? And so
Soup.
the soup, I was just trying to say, like the collection of chemicals that sits there, right? So if we put something through a chemical analyzer and it was acute versus chronic, you see totally different kinds of chemical release.
Yeah, that makes a lot of sense.
Yep.
You know, because you mentioned the immune response, and just for listeners that are going through this, the immune response, for all intents and purposes, really is just like how you heal something for the most part, right?
Totally.
And so my understanding of PRP, and to kind of give that back, is you guys take some stuff out that's from, you know, different kinds of tissues. You generally blood, right?
PRP from blood, yep.
PRP, platelet-rich plasma.
You got it.
Okay, so PRP, take the blood sample, do some magic stuff in your lab, turn around, put it back in the damaged area, and then it helps start off kind of the healing process. And that lasts a couple days. And then on the back end of that, they should feel significantly better. More or less.
Healing process starts in the first couple days.
Okay.
And then changes and extends over the next like 12 weeks.
Okay.
Right. And that data originally came from basic science wound healing data.
Yeah.
But we kind of know after that first like kind of inflammatory phase, then we have a phase of proliferation and maturation. So it's like we're laying down temporary collagen, which is good. That's better than disease and no collagen.
Okay.
Then it's being turned over and replaced by more permanent collagen. That's structurally a better tissue, especially for somebody who's going to jump and cut and land and you know, go back to high performance. So
Okay, so it really sets like a framework lattice that everything else kind of builds on. All right, that's amazing. So we're going to go ahead and take a pause here for a second.
Oh, okay. What time is it?
So we can go ahead and wrap this up.
Okay.
We're going to wrap it. I mean, and there's so much stuff that we probably should do multiple segments.
Man, I'd love to. This is fun.
Yeah, it's a good time.
Yeah.
Okay. Can we? Is it good? Okay, cool. I got you. All right. So, you know, obviously there's a dearth of great information, great therapeutics out here. This barely scratches the surface. And so, again, we'll put your email address in the contact information below. I think that that's a really great start for coaches to start to understand that there are a lot of other methodologies that exist that can really help patient and client outcomes really go and expedite themselves from point A to point B, which is when we think about the nature of being a professional in general, the idea is we want to cut down on the trial and error and the learning curve and the frustrations that go along with that on behalf of the patient or the client, which is how we have jobs.
Sure.
And so if you have any of those questions, comments, concerns, again, like we would love to hear from you. Again, Dr. Trevor Turner here at Provita Health in Atlanta. Beautiful facility. We'll have some B-roll shots for you guys to get some of the backdrop here and really just we really hope to have you on for subsequent segments where we get to talk maybe a little more in depth on some of these other things we've mentioned. I think MFAT would be a great one next. But all that to say, do you have any closing remarks, anything that you want people to think about, these health coaches that are looking for these clinical partners that, would have clients that would greatly benefit from something like this?
Oh, just thank you so much for having me. And, we admire what you guys are doing with the podcast and how you're bringing people together who can leverage collective expertise to raise the bar for everybody, right? So we're only as good as physicians as the rehab team and the performance team, because if we do a procedure like 100 times and we did it great every single time, not everybody's going to get better unless they have an outstanding plan to get back to sport afterwards. So, so we're thankful for your involvement and for the great people that you work with and know.
Well, thank you so much, Dr. Turner. All right, guys. So thanks again for being here at the Beyond the Pump podcast, where we talk about the business of fitness and nutrition. And we'll see you guys in the next one.